Okay, so the next presenting author is Dr. Leshna Koparapu. Okay, so you are presenting evaluation of etiopathogenesis of optic disc edema patients attending ophthalmology OPD. Okay. Yeah.
Good morning, respected delegates. I'm Dr. Leshna, presenting a paper on evaluation of etiopathogenesis of optic disc edema in patients attending ophthalmology OPD. There is no financial conflict of interest. Optic disc edema can be unilateral or bilateral, and causes can be hereditary, inflammatory, ischemic, infiltrative, toxic, or compressive. Clinical evaluation and differentiating causes of optic disc edema is important to arrive at a correct diagnosis. The management and prognosis depends upon the etiopathogenesis of the disc edema. Early and prompt treatment of disc edema will prevent permanent irreversible blindness, which is caused due to optic atrophy. Bilateral optic disc edema could be papilledema, which may be life-threatening unless treated urgently by neurosurgeon in order to relieve the raised ICT and probable space-occupying lesion in the brain. My aims are to evaluate the causes of optic disc edema, age of presentation, sex preponderance, systemic associations, and the risk factors, and evaluation of disc edema using various imaging technologies. Evaluation of different etiological factors, which included like hereditary, inflammatory, infiltrative, ischemic, vascular, toxic, or ocular hypotony due to any other cause. Timely referral to the respective clinical departments like neurosurgery, medicine, endocrinology will prevent the visual morbidity and serious systemic complications. My sample size is 20, and all patients who visited ophthalmology OPD or referred from other departments or evaluated for optic disc edema in NRI Institute of Medical Sciences, Visakhapatnam. And inclusion criteria included children above the age of 10 years and adults below the age of 8 years, both males and females. And all cases of optic disc edema secondary to intracranial, systemic, and orbital causes are included. Myelinated nerve fibers, morning glory syndrome are excluded. All patients underwent a thorough, detailed history of presenting illness, medical evaluation, and a thorough ophthalmic examination, which included assessment of visual acuity using both Snellens unaided and aided, pupillary light reflex, both direct and indirect, color vision using Ishihara, and IOP recorded with GAT, B-scan biometry, slit lamp biomicroscopy, fundus evaluation, both direct and indirect, visual field analysis using visual field analyzer, OCT, ONH, RNFL analysis, blood pressure, blood investigations, which included CBP, blood sugar, lipid profile, all the neuroimaging whichever required, CT, MRI, brain, spine, all the angiography, MRA, CTA, cerebral angiography, carotid Doppler if required to evaluate blood flow dynamics, LP, CSF opening pressure, CSF analysis. All the data obtained, that is organized in Excel sheets and evaluated using statistical analysis applying SPSS software version 2.1. Coming to the results, there is increased incidence of disc edema in the age group of 21 to 30 years, accounting for about 30%, followed by 31 to 40 years, accounting for about 25%. And coming to sex distribution, there is highest female preponderance, accounting for about 65% of cases in females and only 35% in males. Coming to the complaints, 25% of cases were asymptomatic at the time of presentation, which means you need to evaluate asymptomatic patients also for disc edema, and 25 patients presented with only diminution of vision, and 25% patients presented with diminution of vision along with orbital pain and headache. Coming to laterality, papilledema is seen with highest incidence, accounting for 60% of cases, and 30% of cases were seen bilateral disc edema due to some other causes, and 10% cases showed unilateral disc edema. Coming to etiopathogenesis in disc edema, IAH rules its way, accounting for about 55% of cases, followed by non-arteritic anterior ischemic optic neuropathy, accounting for 10% of cases, followed by disc edema secondary to grade 4 hypertensive retinopathy in 10% of cases. Other causes also included like intracranial space occupying lesions, systemic conditions like neurocystic causes, and metachromatic leukodystrophies, thrombosis with aneurysm in the IC, and uncontrolled diabetic mellitus. And association with cranial nerve palsies, 85% of cases had no involvement of any cranial nerve, while 10% of cases showed involvement of 6th cranial nerve with LR palsy, and only 5% of cases showed 3rd nerve involvement. And around 80% of cases showed good visual acuity within the range of 6.6 to 6.18, and 10% of cases showed between the range of 6.24 to 6/60, and 10% within the range of 5/60 to 3/60. Coming to color vision, 75% of cases showed normal color vision, while only 25% of cases showed color vision deficit. And pupil reactions, 75% had normal pupil changes, while only 20% of cases had sluggish reaction, and only 5% of cases showed RAPD defect. Coming to visual field changes, 60% of cases showed blind spot enlargement and 35% cases were not cooperative and 5% showed other defects apart from blind spot enlargement. Coming to the discussion, in my study, overall optic disc edema, bilateral presentation as papilledema, secondary to idiopathic intracranial hypertension is more common, accounting for 55%, especially in the age group of 21 to 30 years, which comes to 30%. My study is in concordance with the study that is run by Anil Parajoli at Koirol Alliance Center, Nepal, Kathmandu. And 80% of people had normal visual acuity and 75% had normal color vision at the time of presentation. In my study, there is female sex preponderance accounting for 65%, which is similar again to the study done by Selma Urfagoli at Department of Ophthalmology, Turkey. Non-arteritic anti-ischemic optic neuropathy is a second most common cause of optic disc edema, constituting about 10%, similar to the study that is done by Ahmad Marwan Abdulaziz at Department of Ophthalmology, Malaysia. Conclusion, idiopathic intracranial hypertension is the most common cause of papilledema in young patients in the age group of 21 to 30 years. Careful history, general and complete ophthalmic evaluation with necessary investigations like CT, MRI, MRV, CSF opening pressure are mandatory in order to diagnose the patients with papilledema secondary to IIH. Accurate identification, prompt treatment, timely referral with appropriate imaging modalities will help us to avoid further compromise in visual function, as they are often asymptomatic with good visual acuity at presentation. These are my references. Thank you.
Thank you so much. We'll take the next speaker because we're running out of time.
Thank you.